I could lose my. I'm bringing sepsis back. It stays so active, shocking, that's a fact. It makes your BP drop oh so fast. So grab a lactic from the fluid snap. Tip it to the lab. Infected babe. You're in the shocking, it's getting great. I start the bump and just don't hope and pray. It's just that sepsis makes you feel the sway. Take him to the unit. Breathe in the blue. Meet search right. She's tagged to. Meet search right. To 102. Meet search right. Let's ship for do. Meet search right. Here's your work biz. Go ahead, get with. Check the UA. For factory. Quick chest x-ray. For pneumonia. Your cultures too. For bacteremia. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. I'm bringing sepsis back. Those microbes unprepared for my attack. Check these broad spectrums I've got on the rack. I narrow therapy by culture track. Give them all the bosun. Septic pain. 4-liter bolus and you're still the same. I start the pressures through the central vein. I hope your BB starts to make some pain. Get them over fusion. Breathe in the blue. Meet search right. She's tagged to. Meet search right. 102. Meet search right. Let's ship for you. Meet search right. Here's your work biz. Go ahead, get with. Check the UA. For factory. Quick chest x-ray. For pneumonia. Your cultures too. For bacteremia. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. I'm bringing sepsis back. I tell you, source control is where it's at. Cut it, drain it, pull it, and that's a wrap. Cause if you don't, they'll die, and that is whack. Take it back, you. Breathe in the blue. Meet search right. She's tagged to. Meet search right. 102. Meet search right. Let's ship for do. Meet search right. Here's your work biz. Go ahead, get with. Check the UA. For factory. Quick chest x-ray. For pneumonia. Your cultures too. For bacteremia. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on. Go ahead. Get your sepsis on. Get your sepsis on.
Guys, go ahead and take a 10-minute break. Really early. Doesn't mean I want you getting out there as primary care PAs and throwing Z-packs at everybody. I mean that these are people that come in, we know based upon serious criteria that we need to get moving on them. And antibiotics is going to be a game changer. So, about sepsis, this is when people have bad enough infection that start having their whole body shut down. Here's your objectives. Here's your run-up case. think our priority is with this patient? When you get things figured out, probably need to start this lady on some antibiotics. She's tachycardic, she's starting to go hypotense. We don't want her to get into full-on septic shock. So infection control and then actually isolating that infection by way of antibiotics. But in the process of doing that, we're gonna be resuscitating our fluids as well, okay? Resuscitating her fluids. But those fluids, yeah, they're gonna probably help out with her tachycardia, probably help out with her hypotension, but ultimately, your priority is antibiotics for these patients. We know that she's got infection. But it's a combination of doing all these types of things. Yeah, we do need to make sure that their hypotension responds to fluids, sure. So, widespread inflammation. This is when it gets into sepsis. This is not just, oh, this person's sick, they have an infection. Sepsis is widespread inflammation. And then organs start taking hits, start shutting down from infection. That's bad, so bad. Starts affecting the heart, liver, kidneys, get into a world of hurt. What's it happening? Now they're getting ischemic, global ischemia, because they're not able to perfuse the body. So that gives us a good idea. That's why we order these lactates. That's why we order lactate. Lactates has to go down on ice to the laboratory. Goes down on ice, gives you a good idea of how widespread is this ischemia happening. And eventually, we're gonna have multi-system organ failure. Very bad. Yep, we still have a lot of people dying from this. Still have a lot of people. So, we're gonna get severe sepsis. Talking about 1 in 5 pass. That's why we want to get on top of this as quickly as possible. Now, a lot of people think it's cavalier in the nursing department to just throw antibiotics at these folks, but it can be a game changer. If you've gotten burned by somebody that comes in septic shock, that's bad. If they're getting septic shock, we're talking about half those people not making it, regardless of how quickly you get the antibiotics on board and you resuscitate them, regardless of those. So, sepsis right there. Yes, suspected or confirmed. Sometimes you don't know. That's why sometimes we're like, oh, I don't know exactly what the infection is, but I'm just gonna grab a big gun. They're usually bank and Zos, and they're gonna cover most things for that. And so if you don't know what's going on, you haven't found where that infection is. So septic shock, that's when we start having problems cardiovascular. We're giving them fluids, but that blood pressure's not coming up, and we're having to reach for other things. Vasopressors. We get increase in that lactate. Anything above a 2 is concerning. Anything above a 2, but persistent hypotension, that means we're trying to resuscitate them, but it's not happening. And then we have to reach for something called vasopressors. It's usually norepinephrine is going to be the medication of choice. But we're concerned because we have met Sears criteria. So I know that video is pretty corny, but it's still pretty spot on. When they talk about Sears criteria, right there, fever, they're febrile or they can be hypothermic, pulse rate above 90, tachypnea above 20, I would definitely know these values. Leukocytosis either above 12,000 or below 4,000. Below 4,000. And then you have all these other types of things that are going to give you ideas. So I want you to pay attention that you know those Sears criteria though. And then you got all these other inflammatory parameters. So CRPs, and then at the sexy lab call a procalcitonin. Internal medicine, if you order one of those on your patient with sepsis, the internal medicine residents are going to love you. It makes you look like you actually know what you're doing. Gives you a good idea that it's either a pulmonary or a GI infection if that procalcitonin is elevated. And then all these other things are going to be general. If you're ordering sepsis, a lot of times it's just clicking the button and it orders all the labs that you need. There's some other types of things. This is really what we're going to start seeing. Internal medicine ICU are gonna be more concerned with a lot of these types of things. These are all different parameters as far as what they're looking for, if this is progressing. These are all markers for the most part of end organ damage. End organ damage. So, you see, creatinine is gonna give us an idea that the kidneys aren't working. Bulgaria, they're not producing urine, kidneys aren't working. Coagulation abnormalities, that gives us a good idea. Oh man, liver's not functioning properly. These are all just markers, different ways that they're going to look at organ dysfunction and gives them a better idea of prognosis within the emergency department. I'm not saying I'm not gonna test you on these because it's not your concern from an emergency medicine standpoint. We'll talk about what your concerns are in the emergency department. So, and you see some of these people are on ventilators too, that's why they're gonna be checking acute lung injuries. It's all done ventilator. So people are in a coma. QSOFA tool, it's a great for organ failure assessment. That's gonna be more an inpatient thing. You're gonna be using your Sears criteria in the emergency department. But I have had internal medicine folks say, well, what's your QSOFA score? I'm not concerned about that, that's your concern. But, just so you know, I mean, how many people, you're gonna use your Sears criteria in the ED. That QSOFA is just how they're gonna gauge that. But if you wanted to just sound cool on the phone, you're talking to them, be like, yeah, here's I think their QSOFA score is. That's gonna be based on their altered mental status, respiratory rate, which is part of Sears criteria, and systolic blood pressure. So, at least 2 of those is poor outcome. But again, Sears is superior from the emergency department, so please know the Sears. I'm gonna ask you a question on QSOFA. Just want you to know, because that's kind of, the language changed a little bit when you're talking to somebody that's gonna admit your patient. Now, what does this mean? Can somebody have Sears criteria and not have infection? Absolutely. Let's say somebody just rolled their ankle and they were outside running in 120-degree heat. They could come in and be febrile, and be tachy, and maybe be hypotense. Just be aware of, there's other types of things that can affect that. Specifically trauma, pancreatitis, burns, right here, here's that breakdown. Sears criteria, these are things that can mimic infection, and that is pancreatitis, burns, trauma, all those types of things can mimic those and also become factors that relate to that. They fall inside the Sears circle, that doesn't mean they fall inside of the sepsis circle. What are we gonna order to give us an idea from the emergency department? We want a lactate. That's gonna be the best prognostic data. It's a great baseline to have, say that lactate's at 5. You can do a serial lactate after you've given them fluids and maybe you've had to transfuse them, give them antibiotics, and you draw another one, and if that's going down, goes from like a 3 to a 4, we know we're moving in the right direction. If you draw another one and it's elevated, you're like, oh, I'm not doing something right. Well, that is a great prognostic. So, gives us addition, lets us know if we're starting to perfuse the tissues again. So if that lactate goes up, there are other things that can cause lactates to go up. Anybody have any idea besides perfusion? Can cause lactate to increase? I'm sure. So, alcoholics. I'm talking like hardcore, like drinking for days. You think about it, that much alcohol is running through somebody's blood system, and that's just how much oxygen is not going to be running through. How much oxygen is not going to be running through, so just give you an idea of that. We want them to start clearing that lactate, meaning that it's going to start dropping. If it's not dropping, then that infection is going too fast, or we're not resuscitating them properly in the emergency department. So, I told you several other conditions that lactate can be increased. Sure, if somebody runs a marathon, course, think about people that have rhabdomyolysis, are gonna have pretty elevated lactate as well. But again, just a marker of hypoperfusion, how bad it is. So, these are the critical events that can occur for failing to control this, not treat it properly. Maybe we picked the wrong antibiotic. But again, there's this hyperinflammatory response. Unfortunately, as it progresses, it starts to blunt. Will not be, that means the body's pretty much failing, organs are failing. And then we get, what's that cool word for cell death? Apoptosis. Again, that's like a $20 word. $20 word, I'd say. So don't use it all the time. But apoptosis, and then cells start dying, and then organs start dying. Bad deal. Bad deal. We're going to start seeing this imbalance, especially when the liver starts taking a hit with coags not being produced. Then we get into DIC, disseminated intravascular coagulation. We start having clot formation, thrombosis, small vessels. Liver's taking a hit, and that means that all the blood's going to start reacting as well. We're not producing those type of coags that we need. So this gives us clues. These are clues that we have something that's going on. Those clues are fever, hypotension, tachycardia. Means the body's responding to some type of infection, giving you all those types of things. Be aware though, some of you may not be febrile because they took some antipyretic before they came in, usually Tylenol or an NSAID. But the type of shock that occurs is known as distributive shock. Distributive shock. So full body vasodilation. So this is a warm type of shock, not typically cold, warm type of shock. And the body's trying to respond with that, and that vasodilation is what's causing that tachycardia, increased heart rate. And then it starts affecting the lungs. Starts affecting the lungs, which is why we have to consider intubating these people pretty early. They get significant lung edema. Lungs are not getting the perfusion that they need. People are getting hypoxic. And then we have to put them on a tube. So mechanical ventilation is not really what we want to do for these people, but we have to. And then it's just going to start backing up. You're going to see all these infiltrates, chest x-ray. Somebody's on a ventilator, they're tubed, they're going to get at least a chest x-ray every day to see how their lungs are working. Also probably confirming that that ET tube is placed properly. And probably make sure their central line's placed properly because they're going to have one of those as well. So lungs, then we're going to see the kidneys going to start taking a hit, so we get that kidney function. We're looking specifically at that creatinine, make sure that it's where it needs to be. And a lot of these people are going to get a urinary catheter to monitor the urine output. Gives a good idea of how the kidneys are functioning. Are they having decreased? In some cases, these people will not even produce any urine. That's how bad their kidneys have gotten. And it's just great markers for all these different things. Lets us know how the kidney's functioning. If they're too hypotense, it's not going to be perfusing the kidneys properly. And then are they dehydrated? And then we also want to be careful if we had to get a CT scan, or there are antibiotics out there that are not particularly great for the kidneys. The kidneys taking any hit from that, any nephrotoxic substance in the form of antibiotics or IV contrast. And then make sure monitoring that creatinine BUN to see if there's any evidence of an acute kidney injury. It's typically an increase of at least 0.5 in somebody's baseline from their creatinine. So we look at that. Hopefully they have an old one that they had drawn maybe a year prior. You can see if that's increasing. Somebody has an AKI early, maybe they're not quite septic, but they're getting that. That is a good reason to admit somebody, acute kidney injury by somebody at admission. If there's an increase in their creatinine of at least half of where it is, so if it's at a 1 and it's up to a 1.5, you can get somebody admitted for that. I can't exactly figure out what's going on, I'm like, oh, he's got an AKI, I'm gonna admit him for that, and let the folks figure it out. Again, their liver, you can see right off the bat, that person comes in and they are jaundiced. Where do we see jaundice at normally? Right in the sclera, right? Yellow in the sclera. But if you get somebody who's got it in their skin, they're getting pretty bad. Just a good idea that that's going on. We're gonna get all those labs specifically looking, our transaminases, those are all our different liver functions. But then you have to add a bilirubin. What does bilirubin give us an idea what's going on? It's usually the gallbladder, the bilirubin's increasing. I want to make sure biliary source of infection. Again, may not know exactly what it is. We're trying to get it figured out. So, and then smaller elevations can also be from ischemia or hyperperfusion, or if there's any type of autoimmune type of diseases. GI, usually an ileus is what happens. Poor perfusion to the entire GI tract is just going to slow it down. It's not getting the oxygen it needs. So what does it do? It just stops. Ileus, it's not going to have the peristalsis like it normally would. This can happen a lot. Very rare that it's a GI bleed. Very rare that it's a GI bleed. But again, anytime that we have stasis in the body, stasis meaning things stop, i.e. in ileus, it's not going properly. Anytime we have stasis, we open the door for infection. If things can sit there, then it allows bacteria to grow. Bacteria grows, it causes infection, so we worry about that with GI. And we can have these little erosions that occur there, the mucosal layer. That's from stress from an infection. However, pretty bad. We're going to see this in the blood happen as well. Sepsis, what's that going to cause? Usually a decrease in neutrophils, decrease in platelets. Lower platelet levels going to cause DIC. Okay? DIC. So, and if that gets fulminant, meaning it spreads through the entire body and starts affecting the organs, very poor prognosis. Metabolic changes, again, we talk about that lactate. That's often hypoperfusion, so that increases that lactate. What's also going to happen is people are going to get hyperglycemic. That's not good. Now we have more sugar. That's more sugar that bacteria can eat up. So you see how we're causing this horrible cascade. Horrible cascade. Not very common that these people get hypoglycemic, but you still want to monitor that. So, what do you think about hyperglycemia now? We're like, man, maybe this is DKA caused by infection, right? So, get worried about that. A lot of these type of people are coming in if we can't really figure out why they're septic. This is an older person that's in a nursing home, and maybe they're bedridden. These people, we have to take a good look at all of their skin. You roll them over and they've just got this monster ulcer that's been on their back from laying in bed all the time. So we want to make sure that we're ruling out all these different types of skin issues. You got your direct, which has to do with the cellulitis, and erysipelas, fasciitis. So pain out of proportion is fasciitis, necrotizing fasciitis. Anybody seen that? That's bad. That's a surgical emergency. That needs to go to the OR right away. That'll kill somebody real fast. And then you got all your other interesting type of lesions, petechiae, pustules, necrosis. You get all these different types of vasculitis because these people have underlying peripheral vasculitis, and then toxic shock syndrome. But again, looking for any necrotizing surgical source of sepsis. If somebody has a surgery, I'm going to call that surgeon at some point. Say, hey, baby, they seeded some type of infection while they were operating for whatever reason. And then necrotizing, I told you that. It's pain out of proportion. Pain out of proportion. It's pretty nasty. They have to go in and remove whatever tissue. Have to remove tissue. You do not delay antibiotics. You need to get on the antibiotics right away. Antibiotics right away. And that's typically within an hour. Within 1 hour, that person needs to get antibiotics. Why? Because we've met at least 2 of the 4 Sears criteria, we definitely know that. And then we have a suspicion based on that. We need to try and figure out what type of symptoms are they having. Have they been coughing? Were they exposed to somebody with COVID? Were they swimming in some mucky water to get an idea of what's going on and what we need to treat? So septic shock, if we give that person an initial fluid bolus and we cannot get that systolic above 90. And then what's the other thing? Why do we get that lactate? Anything above 4. Above 2 is abnormal, but we're thinking sepsis if we're above 4. We are above 4. You start thinking of what's going on. There can be other causes of shock. Obviously, we're talking about sepsis, so more along the lines of a distributive. But there can be a mixed picture there. All those other different types of things. We want to make sure that we're eliminating those. So, PE, cardiac tamponade, endocrine disorders. So, undifferentiated shock in the ED. 4 out of 10 of those people are going to have sepsis, underlying sepsis. And then I get really worried about old people, and I get worried about little kiddos. Because old people deteriorate real quick, and then kiddos fight it for a long time, and then once they get hypotense, it's usually very late in the disease process. So just be aware that kids can show up looking awesome and then tube real fast. We have all these different types of labs that we want to gauge on. It gives an idea if there is some occult bacterial infection. Pan culture, what does pan culture mean? Pan culture means that they're going to get blood cultures from 2 different sites, usually 2 different arms. Now if they have a port or they have a fistula, we need to get that checked as well. But then we're also going to give a urine. So we get all those things, we get them ordered right before we're slamming with antibiotics. And see what those cultures grow out to make sure. But there's all your labs. So electrolytes, usually that's going to be that basic metabolic panel along with the renal function. You can order a liver function separate if you don't want to order a CMP. You could order liver function, and then obviously get your analysis. If I'm going this way, I'm definitely getting a VBG. Definitely getting a VBG. I need to see if they're acidotic. I need to see how they're perfusing. I need to see where their O2 sats are within that. And then I type in screen. I order type in cross if I think I'm actually going to have to transfuse somebody. Yeah, it gets to a last ditch effort. If they don't have the RBCs to carry the oxygen to the body, then we need to potentially look at that. So there's all your coag panel, which will include all those, and then we'll order a D-dimer just to make sure there's not some underlying blood clot. Make sure it's not some underlying blood clot. So essentially, we're just going to be, you're going to hit the sepsis button and it's going to order all this stuff for you. What else do we need to get? Not everybody can auscultate the lungs and hear crackling, so we're going to get a chest x-ray to make sure it's not some underlying, is this a pneumonia? That might give us an idea that we're going to reach for different antibiotics. You can look it up on the internet. Everybody heard of what a Sanford is? So Sanford is basically antibiotic guide. Tell you, oh, I think it's a pneumonia. Here's the antibiotics that you can reach for. It's a great thing. I will confirm if I'm calling to get that person admitted, I'm going to say I'm going to start with these 2 antibiotics. Do you have anything else you want me to cover? Or would you prefer that I go with something different? Absolutely. I'm making that decision. I'm calling. I'm like, I got a septic person. I'm ordering the antibiotics and I'm calling. I'm going to get them upstairs as soon as possible. A lot of these folks that they can't figure out what's going on, maybe they're having abdominal pain, we need to get a CT of the abdomen. And we need to get CTs of other things, the chest, based on what other symptomatology. We're going to try and get that figured out, figure out what is the source of that. So right there, intra-abdominal sepsis, that's the best way we're going to do that. We're not just going to rely on physical exam, we need to CT their abdomen. Or maybe they have right upper quadrant pain, so we're going to get an ultrasound because we're worried about a biliary cause. Or whether that's cholecystitis or choledochlothiasis, we'll get more into that and block through 3. So soft tissue, CT, ultrasound, potential. We're gonna do a good physical exam with people, trying to figure out what the source is. And then just maybe we get a CT and LP if they're having headache, nuclear rigidity.
Sir, I know most of these studies are based on like a patient presentation. Are you just gonna like hand order a chest X-ray for any sepsis patient?
Pretty much. That inpatient team's gonna want it. So, I mean, I'd have a little bit of a reason, like that person said, yeah, I've been coughing up gunk and I have fever, but for a lot of these folks, I mean, our trauma patients coming in, they're gonna get a chest X-ray portable, and they're gonna get a pelvic on everyone for trauma patients. So mostly for these, if they're sepsis, a lot of it is just a matter of clicking the button, and all this stuff's gonna get ordered, aside from CTs or ultrasounds. But everybody's pretty much gonna get a chest X-ray. So a lot of times you just don't have a good idea of what the source is for the sepsis. And then everybody's going to get blood cultures, for sure. And if they have any other types of thing, a port, a fistula, we're gonna get a culture off of that as well. So it's just a matter of ordering those cultures. They'll go down, nurse will get it, take care of that. So, and then plus or minus on whether CRP or procalcitonin based on your military treatment facility, they should have guidelines for what they want on all their sepsis people. So we don't want to focus on the treatment. These 3 main tenets. Early recognition. We're looking at vitals, we're looking at ABCs, we're looking at Sears criteria and what does it meet. And then early infection control. Infection control is defined as I'm going to start this person on antibiotics. After I've gotten all their labs, after I've ordered their pain cultures, and then start them on antibiotics. Okay? And then reversal hemodynamic compromise. So that's giving them, as we're giving them antibiotics, we're also starting on fluids. Could we potentially pressure bag that in? Absolutely. And if they don't respond to that initial bolus, which is typically going to be anywhere from 1 to 2 liters, and that systolic does not get above 90, we need to reach for vasopressors. And I'll talk about that here in a little bit. But I want you to focus on those 5, I want you to focus on those 3. Those 3. And what are our goals here? Now, if there's not enough fluid in the tank, meaning we need to increase the preload, that's why we give fluids for that. It's going to help out with tissue perfusion because they're so vasodilated and volume down, and increase that oxygen delivery. Right there, 2 to 5 liters of crystalloid within the first 6 hours. So we're sending these people with a lot of fluids. And then again, if it does not respond, we need to reach our vasopressors. Now is that vasopressor just going to be sitting right there inside of the crash cart? No, it's going to have to come up from downstairs. So a temporizing thing is push dose epi. So not an epi auto injector. We are going to reach for crash cart epi. Very simple. You take a 10 cc syringe, you push out 1 cc, you load that up with 1 cc of crash cart epi, 1 over 10,000. Okay, and then you're going to push that temporizing until that norepinephrine comes up on the Pyxis or whatever. And you're going to push that usually 1 cc at a time. It's just temporizing until that norepinephrine is right there. And if you have to, reach for other medications, I got a slide for that and we'll talk about. So usually 30 milligrams per kilogram or cc's. Right there. Now it's usually 1 to 2 liters for a normal person. If you're giving 2 liters and it doesn't do the trick, you think 2 more is going to help out? Probably not. You need to get something on board and get that. Norepinephrine is going to be what we're going to go for right there. Best first choice. And why does that work so well? Because it acts on both alpha and beta adrenergic. So it causes peripheral vasoconstriction and increases the heart rate. It's cardiac entropy. So what's our second line? And when I say second line, that means that you're adding it to the norepinephrine, but vasopressin is going to be your second line. I would know both of those. Those are your medications of choice. And again, push those epi horizon. Is the potential to add epi after that? Sure. Especially in somebody that's just having septic shock, you may need to reach for other types of things. It used to be that this was only given through a central line back in the day. You had to put a central line in. Not anymore. You can do this peripherally now. You can do this peripherally. But at some point, they probably do need a central line, especially if we're reaching for blood product. Then, what do we use to gauge that? That lactate is the biggest thing that's going to guide us through this type of therapy. So we know that if that lactate's decreasing, that we're perfusing much better. Usually, if they're in the emergency department, lactates are drawn every 1 to 2 hours, probably every hour. Draw that, get it figured out. And then we want to get broad spectrum antibiotics. Now, I'm not going to ask you questions on which antibiotic you give. You just need to know antibiotics you give them within an hour of identifying this. Why? Because people die. I told you that septic shock, half those people are going to die. And antibiotics are going to be a game changer. Right here, 1 hour. You could ask a question on this in the future, like this week. 1 hour. 3 hours of triage, but within 1 hour, antibiotics are going. So, we want to sample our infection source, obviously get into cultures. But I'd say we can't get that. I would say between getting cultures and IV antibiotics. Okay? I have a phase 2 question out there where there's a question that says, person in septic shock, what do you need to get next? The answer is blood cultures. Because there is one other question, or one other answer there, that says giving oral antibiotics. You don't give oral antibiotics in sepsis. You give IV antibiotics. And mess around. That's one of the things about the ER. If you can give somebody some IV antibiotics, it's going to get on board. You don't have to wait for that second pass effect, which means it has to go through the GI tract. Rather, when I can put it right in the bloodstream, right? Very smart. So, and nowadays, we're going to think about everybody's going to get a COVID test as well, just so you're aware. So you need to know what their status is, because they're not going to put somebody with COVID in a room with somebody who doesn't have COVID. So, and then also droplet control has to be considered with these folks. Droplet control. So, especially if you're thinking this person has C. diff because they've been on antibiotics already, they're not getting better. This is just an example. I'm not going to test you on this. I just want you to have an idea. This is pulled right out of technology. Gives you an idea of what do I think is the course, where is that source at, and here's the antibiotics that I'm reaching for. Now your MTF may have certain biograms, meaning they know what most urosepsis, so urinary source, which antibiotics to go for. They'll put that out to you. Like certain places will treat urinary tract infections with certain antibiotics because they know what the likely cause is. Again, this is just to give you an idea of what type of things that we reach for. You've got to have an idea of potentially what the cause is. Otherwise, you're just going big gun. I get worried about people that are immunocompromised, HIV, cancer patients, people that are on autoimmune medications because that causes them to be immunosuppressed. Worry about those as well, so reaching for a bigger gun there. Anyway, just gives you a good idea of that. Questions on sepsis? Check on learning. And then we're going to push on into anaphylaxis because that will just give us more time to finish up for Wednesday. So I don't want to be here either. First choice. Everybody agree C, right? Third choice would be B. Don't pick the B to me, I didn't talk about that. No. So what do we think? Do we think it's A or do we think C? Yeah. That is, C is the same thing twice, right? Because that's what they consider removal of the infection versus by initiating environment. So really, it's A, we need to correct the hypertension and infection control. It's not on the test, don't worry about that one. I said 3, so it obviously can't be C. Everybody likes E, right? You should, because that's the correct answer. All right.
How can it be like she was drawing the last one? You just said everyone the same thing.
What do you think? A or E? A. Like A better. I won't be able to see it. All right, I'll save one more video for Wednesday, but we're gonna get into